Hello, everyone, and welcome. My name is Brianne Lessner, and I'm a program coordinator at AVAC. We are so excited to welcome you to the Research Literacy Networking Zone. The zone is an informal space organized around major conferences as a place where advocates and researchers can really come together and dive deeper into the science and into the issues that are surrounding the science that come out of conferences. And really, it's an informal space. We have some great speakers lined up today, but we invite you at any time to share your thoughts or questions in the chat. You can raise your hand or come off mute to ask questions. We really want this to be an interactive space, and we certainly hope to have time, and we've planned to have time for lots of dialogue at the end of the call. So with that, I'm going to turn it over to our facilitator, Alice.
Thank you so much, Brian. And if you may allow me to start a video, if that is fine.
Absolutely, Alice.
Thank you. Thank you, and good afternoon, good morning to everyone who's here. Welcome to the networking zone. And today we'll be speaking about vaccine hesitancy. I am sure we all know and we have heard about vaccine hesitancy in our countries. But before we get into that, I would like to introduce myself and mention that my name is Alice Kayongo. I work with Waki Health as Senior Policy Advisor. I'm so happy to join you all for this very interesting discussion and to learn more about what is happening at different country level. First off, the Africa region has a huge surge in COVID cases. And just, the last that I checked, we have over 6 million cases to date, while we have over 153,000 deaths. But right in the middle of that, we know that Western countries are actually vaccinating their populations as wide and as far as possible. We have been told that Western countries vaccinated almost over 80% of their populations, whereas Africa has vaccinated slightly below 2% of our populations. And in the middle of all that, we still have vaccine hesitancy. There's a lot of hesitancy actually going on. And the recent report indicates that we have hesitancy ranging from 36% to 86%, with differences in specific regions. We have Western and Central Africa recording the lowest cases of vaccine confidence, whereas the other regions, we can say they're somewhat doing better. And given all that, we know that there are some countries that are actually going an extra mile to include or to be able to sensitize their communities and basically improve the vaccine hesitancy situation so that we see much more confidence. And that and much more is what we will be able to hear about and learn about and even ask more about during the discussion today. And today I have two very good panelists that will be taking us through what they have done and what they intend to do. I do have Lillian Benjamin, who is a passionate sexual and reproductive health advocate and an adolescental and young women's technical advisor for the Compass Africa at Tanzania Youth. Lillian co-founded the DARE organization for young women, which focuses on promoting young people's access to social and health services. Welcome, Lillian. At the same time, we do have Nida Mora, who is a senior research manager at the HIV Prevention Research Unit of the SAMRC in Durban, South Africa. Her research is focused on understanding acceptability and use of biomedical interventions among women, and more recently, on men's responses to the vaginal ring. She is an advocate for participant and community voices to be part of research programs. Welcome, Anita. And I would like to start off by posing my first question to both of you, and maybe Nia, you could go first, asking about what concerns are surrounding the COVID-19 vaccines. What are the concerns surrounding COVID-19 vaccines, or some of those that you think have been, you are most frequently hearing about in communities, social media, from your different circles? Please share with us some of those that you have heard. Nida?
So good afternoon, good morning, good evening, welcome, and thank you very much for everyone for joining, and thank you to the organizers. So I think before I even answer the question, I wanted to highlight the issue around the term vaccine hesitancy, because it appears that it's kind of a negative term, and we should concentrate on the term vaccine confidence in order to address some of the issues or the concerns. But directly with regard to the concerns in terms of vaccines and access, what we're finding in our setting is the issues around political factors, religious factors impacting on not so much not wanting to access the vaccines, but a hesitancy in that they are still thinking about it. And the gap in that process is the need to address some of the concerns, some of the misperceptions. Social media has had a serious impact on lack of vaccine confidence in South Africa and in our setting. But having said that, in South Africa, when a research was done a few months ago, 67% of the adult population did say they will get the vaccine, and we're hoping to see that being accessible by the communities. In terms of the other concerns that we're finding is linked to economic factors, also political factors. As you can understand, in Africa and in South Africa, it's linked to HIV, and is COVID-19 here to impact on the population or eradicating the population? So I will pause there. Thank you.
Thank you so much, Nida, and thank you for taking us back a bit on what vaccine hesitancy is, as well as vaccine confidence and the issues that you have highlighted. So I would like to pose the same question to you, Lillian, which is what concerns are surrounding COVID-19 vaccines are you most frequently hearing as being raised by your communities and on social media, or even within your networks, your social networks?
Thank you so much, Alice, and everybody for joining in. I spend a lot of time on social media, and I do a lot of community engagement and dialogues from time to time. And I must say, actually, it's pretty evident that in the middle of the pandemic, we've been fighting an infodemic here. As in, since COVID-19 was declared a global emergency, there's been a lot of conspiracies going on, but also COVID misinformation going on, which travel faster than even the truth about the virus. And generally that has imposed fear and, a lot of false information in our communities. So one of the biggest concerns that I get to hear, I've had frequently, has been how people have been comparing how we only had COVID in less than 2 years, and we have a vaccine rolling, but compared to HIV, where we've been fighting against the virus for over 40 years, but we still do not have an effective vaccine. So people are trying to compare the two. Why is it that we have a COVID vaccine rolled out faster compared to an HIV vaccine? And considering both are causative agents of the diseases, have the viral nature. A second concern has been around how countries, especially I'll talk about, I come from the United Republic of Tanzania, and that, generally from the southern part of Africa, some countries have been lucky enough to have some of the vaccines, rolling in their countries, and people are already questioning the quality of vaccines that are brought to Africa, for instance. So there's this perception that the Moderna and Pfizer are like the best COVID vaccines one can get, and the rest are not as quality as there's just that notion going on that they're not of the best quality. So that too has been raising a lot of questions, and it's also another concern I get to hear from people coming from a setting where we do not yet people do not yet have, not everybody has access to the vaccine. There's been a lot of now, religious factors coming in, people talking about, how vaccines are related to some, New World Order, etc. That's what I can think of quickly. But there's been a lot of faith-related concerns as well, as people would say, because of their faith, they find COVID and COVID vaccines contradictory, all these together bringing in, hesitancy, and it really affects people's decision to either taking or not taking the vaccines. But also there have been terms used by some authorities that vaccination should be mandatory, but understanding the concerns around consent, and there have been questions around why are people trying to force vaccines into communities? Why should they be made mandatory? People have the freedom to choose whether or not they take the vaccine, etc. Thank you so much, Alice.
Thank you so much, Lillian. And you raise key issues that we are hearing not only in Tanzania, but in many parts of Africa. I was speaking to friends in Zambia and Zimbabwe yesterday, and these are some of the key issues that are being highlighted. Issues around why is it that for almost 4 decades we don't have a vaccine for HIV, and in less than 2 years we have a vaccine for COVID-19. So that and what you have mentioned are really key, and those are some of the issues that we surely need to focus on as a group, as a community, to be able to fight vaccine hesitancy. So my next question, and again I will go back to you, Nida, asking on what do you think then needs to be done to effectively address the concerns that you have mentioned?
So thank you very much. And so before I even say what should be done, I want to also recognize the fact that in Africa and in South Africa, a fair amount of activities and strategies has already been implemented. And together as a group of advocates, researchers, and many colleagues here who are driving stakeholder engagement, both nationally, locally, and internationally, we need to add more effort to that process. So the things that really needs to be addressed is some of the social, contextual, and religious factors. Religion has played a major role in South Africa, but also in Africa. And in fact, 2 weeks ago, there was a great webinar for 2 hours by a religious sector using the scriptures to explain that vaccines can be taken. There was a notion here that is the vaccine ethical for certain religious groups to take. So it is quite heartwarming to see religious sectors coming together to address these issues. And what was really great was, and which we need to do more of, is to listen to a religious member of the community together with scientists, together with a medical practitioner treating infected patients, talking in one voice about the importance of accessing vaccines, and that there's no religious barriers to it, and demystifying and addressing some of the myths. The other thing that really needs to happen much more than what we are doing now, people like myself are not necessarily the voice of addressing confidence, because we need to hear from the trial participants who have been taking part in many of these trials, going through a consent process, going through many medical procedures in order for these vaccines to have the results that we have. And so we really need to hear their voices. And I believe that on this webinar, we will be hearing a voice of a participant, which is exciting. The third aspect is that in Africa, there are many trial sites, and the community liaison officers, community educators, community managers have done a sterling job of education, outreach, engagement, I think for over a decade. And I don't believe that the vaccine groups have embraced and engaged this wealth of knowledge and experience and skills that we have, not just in terms of trials, but really being the advocates and educators and outreach workers. So that's another area that we need to enhance and concentrate on because it's really critical. The last thing I want to say is that we find the social media overpowering us as scientists, as researchers, globally and internationally. Last week, there was a message around a vaccine's not working because it has proteins that is causing autism. We see very little response locally or internationally or nationally on some of these key social media messages. And so as a result, these social media messages has a powerful impact in the lack of where they are promoters, educators, meeting, or addressing these misperceptions hands-on. So I will pause there. Thank you.
Thank you so much, Nida. You raise very important questions and issues, and starting off with social media, we all know how much social media has done lots of promotion, but it has also affected some of the good work that we have done. I couldn't agree enough with you. There's lots going on, and a lot of it is actually taken on wholeheartedly by many individuals. And coming to the issue about, the religious component, and some religions actually speaking against vaccines, and the need that right now we actually have to go back to our religious leaders to bring them on board so they can speak about the importance of vaccines. That is very key, I must admit, because I think so many people have lost loved ones as a result of vaccine hesitancy, but much of it has been driven by religious connotations. So I'll turn over to you, Lillian, to let me know, what do you think there needs to be done to effectively address the concerns that you raised with regard to misinformation, the vaccine having been rolled out within a short while, the quality of the vaccines, and so on. Please share with us, Lillian.
Okay, thank you so much, Alice. So from my end, what I think needs to be done, my very first and foremost opportunity, I find this is the biggest opportunity to the HIV vaccine / cure research, considering people have been comparing HIV and COVID a lot lately. This is an opportunity to communicate, to find ways to communicate the reasons to why HIV vaccines has taken forever to get rolling, and to get people to actually understand the difference between the two, and why is it that we are yet to, be able to get a working vaccine when it comes to HIV, and show them how far the process has been and where we at the moment. And I think this focus really needs to also go to clinicians and physicians, because part of the population that I've seen somehow joining hands with spreading fear among communities have been medical officers, medical doctors. I know it's human to be scared when something new comes to life sometimes, but they've been the ones, again, communicating such information to the people like, okay, HIV has taken forever, COVID has taken this short amount of time, forgetting their role as clinicians. A person who is not a medical personnel, if they hear them talking about such information, it gives them more confidence to, shy away from the vaccine and, validate all the false information they get to hear from different channels, including social media. But also I think it's necessary to do mass community sensitization about COVID vaccine. Perhaps we overlook introduction of the vaccine into our communities. I know it all happened in the middle of a pandemic. It was emergent. In the middle of an emergency. we didn't have, we're juggling a lot of options. We didn't have much time to perhaps communicate and introduce the COVID vaccine the right way into our communities, but we still have time to do that now. So it's necessary for authorities, national ministries of health to take leadership of sensitizing communities, understanding that people really value their influence and they listen when they communicate, and making sure that we do not just do that. They do not just do that on their own. It's really necessary to engage and coordinate with as many civil society organizations, because at the end of the day, the ministry could be just a few, officers in different councils, but then the people who actually are closer to the communities are civil society organizations. So giving civil society organizations the power to sensitize and, share information, create demand in our communities with regards to COVID vaccine, but also communicating the right information. But also, I secondly, as regards to using popular opinion leaders, we have religious leaders and a lot of influencers. These days via social medias, you can have a lot of, they call them macro and micro influencers. These are people who have huge following and they can actually get people to do something. So we can also identify those influencers, train them, educate them, making sure that they understand what they're talking about and use them to communicate these right information to the people. And last but not least, making sure that the vaccines are available. We see how some countries have access, some don't. Some people can afford, some can't. So how do we make sure that we get these vaccines available for everybody? Making sure we have vaccines, COVID vaccine equity, and whenever people now we create demand, people should be able to access them at the end of the day. Thank you so much.
Thank you, Lillian. I do like what I hear from both of you. The fact that you both really emphasize the role of the community. Neither talked about, research or research participants and community educators being, they shouldn't only be used for research, different researches that are going on, at least, for example, like what is going on in South Africa, but much more for educating the communities as well. And Lillian, you do mention that too, the need for involving communities, the need for involving civil society organizations. That is really key, because at the end of it, it's that community members usually will listen much more to peers and much less to, other individuals that we think are much more superior than we are, because we don't easily relate with them and we find ourselves being somewhat different from the others. But if we hear from those with whom we share so much, those who we identify with, then it's highly likely that we will gain much more confidence in the vaccine. And you also mentioned the fact that, the vaccines need to be available. Unfortunately, they are not available. Only less than 2% of the population in Africa has been vaccinated. We are expecting much more from the COVAX facility, but even then, our own governments are also not putting in enough, to be able to procure enough vaccines for us. So I do hear you on all these issues, but as we go on, I would like to find out, and maybe this time I'll start with you, Lillian, on what do you think are the specific roles that the different stakeholders should play in building vaccine confidence? I know you have mentioned some, at least with regard to religious leaders and influencers, but what about, donors? What about advocates like you and I, the government? What more should, stakeholders, what role should they play in building vaccine confidence?
Thank you so much, Alice. Like I had mentioned, that is actually necessary, not necessary. At this point, governments must take leadership of the making sure that communities have access to vaccines, but also ensuring that ownership of these interventions goes to the communities. They put communities at the center of interventions, rolling out COVID vaccines, sharing information, and etc. As for donors, My biggest concern would be around, and I was just peeping through the chat and I saw someone sharing an example of how apparently there are some vaccines that are labeled, are not considered good quality vaccines when you go to other countries. I think just that is a big issue for me, knowing that my country, for instance, can go heaven and earth to ensure that I get a certain type of COVID vaccine, only to be told that I cannot, it is not considered valid in another space. It raises questions, and perhaps this is why communities keep questioning the qualities of COVID vaccines. So I think it's necessary, if we think there are differences in the qualities, why not ensuring, now we go back to equity, why not funding, ensuring that we make the so considered quality vaccines available for all communities. And if that's not the case, that all vaccines are proper, perhaps we need to hold these countries that segregate certain types of COVID vaccines accountable. That is not the right way to do it. They impose more fear to the people than they do good. And maybe another group that I would like to focus on would be our role as civil society organizations, and as well as researchers. I like it that we have this space today to discuss issues that are rising as regards to COVID vaccines. Perhaps we need to create as many platforms as possible where we have researchers and communities and, community members, civil society organizations, government officials be a part of these dialogues and discussions to come up with solutions on how we can make sure that we build confidence in our people as regards to COVID, vaccine uptake, but also making sure that people get the most quality vaccines possible. Thank you so much, Alice. Over to you.
And yes, thank you, Lillian, for this that you have mentioned. You really emphasize the issue about quality, and that has been very key. Just recently in the media in Uganda, we were told that a significant number of those vaccinated were actually vaccinated with water, and the same was reported in India, I think yesterday on CNN, that over 2,000 individuals had been vaccinated with a saline solution. So now that definitely makes us question the quality of the vaccines that we are getting. When we hear stories of, Africans, vaccination certificates being questioned when we go to Europe, because AstraZeneca, the vaccine that we are vaccinated with, it's questionable. It hasn't been approved by the European Union, and that we actually have to undergo vaccination again if we are to fly to Europe. All that really makes us question the quality of the vaccines that we are getting in Africa. But before I preempt what Nida has, I'll turn over to you, Nida, to find out from you what you think the roles of different stakeholders should be. And I did hear from you with regards to some stakeholders like the religious leaders, community educators. I would like to know if you have any more that you'd like to share with us. We'll be happy to hear from you. Nida?
Thank you very much, Alice. So, I concur with Lillian's points about civil society, and I want to start with the critical role and power of civil society. As some of you may be aware, in South Africa, we're undergoing some unrest and riots. And one of the highlights of that event in the past week was the role of the civil society, what we call the community police forums, and community members, many of whom are on this group, protected the community from violence. And so we can never underestimate the power of existing community structures, community leaders, and civil society. And for us, this is a real experience. And if you watch the media, you would learn that the community forums protected the community and protected food supplies. So taking that lesson, we in Africa, while we may not have access to vaccines, but what we have is that level of advocacy, we have a wealth of experience and tenacity and resilience. And I think we need to optimize this advocacy and resilience and demand much more than we have to access biomedical interventions or other interventions. And linked to that, one of the things we should do more effectively is when we are engaging with sponsors on testing these biomedical interventions, and many of these biomedical interventions like COVID-19 vaccines have been tested in Africa and in South Africa, is to negotiate upfront the access issues. Negotiate upfront with sponsors, with donors, with funders. What is the role they're going to play to capacity develop not just our researchers, but our manufacturers, so that there's intellectual property to make more of these vaccines. We do not want to be dependent in Africa on other external people for the rest of our lives. So I think that's critical. And I must say in South Africa for COVID vaccines, the Aspen pharmaceutical has begun to develop. There's exchange of intellectual property. The SAPRA group, very critical group from a regulatory point of view to address your issues around vaccines being inadequate, poor quality. They play a critical role in ensuring that these vaccines are good quality and are safe for the well-being of our people. I mean, you will be aware that the J&J vaccine was returned, broke my heart, but it was returned because the pharmaceutical company in the US, there was contamination and good pharmaceutical practice was not followed. And so we must recognize the role of regulatory bodies like SAPRA and engage with partners in Africa to work to ensure that these myths about us getting water or giving saline is not accepted. So I think the regulatory groups are critical. Like I mentioned before about the political factors, we must start now to ensure that other countries do not stop people from Africa from entering or questioning the vaccines we have taken, because we are partners in this process. And if we don't advocate that now as a group, as scientists, as researchers, we are actually having lack of integrity in what we do. The other great thing that has happened in South Africa, and I've been fortunate to work in Sasonke, was the South African Medical Research Council, together with many partners conducting this implementation study, worked in partnership with our local government. And we cannot expect government to do things because they need support, they need assistance. So we have to put our hands together to make this effective. And we were fortunate that we have the support of local government, national government, working with the regulatory bodies and asking the hard questions. And the last thing I want to say about what we can do more is, we as researchers, advocates, we need to say to the communities out there in a transparent way, following good participatory practices, that we do not know for sure. It's a new virus. We are learning as we go along. When new information comes, we stop, we pause, we share. You may have seen reports this week coming up about the side effect of ivermectin on liver. And the pulmonologist in Midrand has shared some data. So I think it's important that scientists, researchers say that we are learning and we don't know enough. Make a decision that's informed and a choice that is contextualized within the individual, the family, the relative, and of course, the political and religious context, together with empirical data. I'll pause there. Thank you.
Thank you so much, Nita. You have raised very, very good issues as you were making your submission. And I could honestly, I can't agree enough with all that you have mentioned, researchers getting together. I like that, researchers getting together, stop, pause, and share, what is it that we are seeing, and then accept that we are still learning. This is totally new. Every day there is something new that we are learning, and where there are mistakes, we should be able to acknowledge and own the mistakes that have been made. The role of the regulatory bodies, that has actually not even been mentioned anywhere before, and I am happy that you have mentioned this, because I look back at a country like Uganda, for example, and I wonder, so we have a regulatory body that usually, it tests all these medicines that get into the country, as well as those that have been manufactured in the country. But how this missed them, I cannot tell. The same for India as well. One would imagine that countries like India, for example, have very, very strict regulatory bodies, but how they missed, the science solution, only, no one can be able to tell that. And I know that from our audience, there are a couple of organizations and individuals that are involved in different strategies that are addressing vaccine hesitancy. Many people are saying that, we can't even start talking about vaccine hesitancy before we talk about vaccine equity. But I personally think that the two go hand in hand, because we remember, before we had a surge in Africa, we had, some vaccines, although they were in very low quantities, we had them. But unfortunately, we did not have health workers coming up to pick vaccines, not even the elderly. There was a lot of hesitation. So I think the two go hand in hand. Equity, yes, but we also need a confidence so that, when the vaccines get to different communities, then the communities are actually able to utilize or to uptake the vaccines. And so at this moment, I would like us to, to turn to our audience to find out what are the different strategies and tools that you have been involved in or you have been using to be able to build vaccine confidence in your respective countries. And I know that we have Kizat here from Zimbabwe. Kizat, would you like to, do we have someone from Kizat online who would share with us the different tools and strategies that you have conducted?
Hi, everyone. We've got Kani and Dev. Kani, would you like to say something?
Hi, Babs. Yes. Hi, everyone. So as PZ, we haven't done much really. So we're in the process of developing tools, all in an effort to work on the vaccine confidence work stream. So PZ has developed about 5 tools. We've got the key informant guide, the individual consultation guide for vaccine recipients. We also have the individual consultation guide for the vaccine hesitant category and the COVID-19 survey. We also are working towards finalizing our community consultation guide. So we've sent all these documents to various people to help us review and see areas where maybe we could have missed certain or important issues that we could include in these tools. Over to you, Babs.
Thanks, Kani. So just to chime in, I had written a comment in the chat box. My name is Babs. I also work for Pangaea. What we're trying to do is to really build on what has been contributed already around vaccine hesitancy. So a couple of surveys have been done in our country, mainly with the urban populations, but we're realizing that not much has been done with the rural folk. And unfortunately, with this third wave, it feels like it's actually showing that the rural people in the rural areas are more affected. And the challenge that we are contending with right now is that initially there's just generally been a low risk perception all around. There's been a perception that COVID is for urbanites and not people in the rural areas. So in as much as a lot has been done in terms of mass media communication through the Ministry of Health and vaccines being availed for people have not actually been coming out in the numbers that were expected. Some health workers have not been able to take up the vaccine. We've got religious leaders who've been coming out and saying you shouldn't take the vaccine. It's not a good thing. So what we're trying to do is build on that, identify more gaps, figure out what has motivated those who actually came in for the vaccine, and try and address barriers that emerge. So we'll do a rapid assessment. We are going to do community dialogues in the rural areas. As you can imagine, because of COVID right now, we are not going to be able to get into communities right away, but with small groups of people and sometimes virtually, with key leaders and key stakeholders, we really want to have an in-depth inquiry to inform the national strategy, the communication strategy, and also just to strengthen vaccine confidence in Zimbabwe. Thank you.
Yeah, maybe just to add on that, so from some of the meetings that we've conducted locally, we were informed that risk perception is still very low, both in the both in the rural setup and the urban setup. So we also were informed that risk perception can be changed through radio message or sending messages. So there has to be other strategies that will help us get to the people and be able to improve vaccine confidence. So some of the strategies that were mentioned were like, face-to-face or engaging the community directly so that we're able to reach to the communities and boost their vaccine confidence.
Hello.
Thank you. Okay.
Hello.
Yeah.
I joined this. Hello. I'm saying I joined this conversation midstream, but I think for Kenya, I know with this pandemic, everybody wanted some help. And then when the vaccine came, everybody expected that and people would take the opportunity to get vaccinated. However, I think it would have been better if an engagement was done with healthcare providers. When you have a new product and healthcare providers are not its advocates, it takes time. And then living in a small world, some of our vaccines were to be supplied from India. And about that same time, we were told many Indians were dying in their thousands, yet they had that vaccine. It gives people reasons to doubt.
Thank you, Charles, and thanks to the team at PZAT. I see that we have a couple, contributions in the chat. Please keep them coming, and maybe Brian, you could be able to mention some of them, or we could request Rowan or Nombasa share. We know you have shared on in the chat. But if any one of you would like to mention that to us all, you're welcome. If not, then maybe Brian, you could share some.
Absolutely. And also happy for folks to come off mute. I see that many of these questions, the chat has been so great. Many of these issues and questions have been addressed throughout our dialogue and by speakers. I see that that Mombasa has a question here. In looking at the similarity between HIV and COVID-19 life cycle, and as they are both viruses, why is HIV taking longer? That's a great question. I wonder if any of our panelists would like to take that question.
I will try, but I just wanted to recognize the comment by one of the groups, I think it was Ari, about having posters and behavioral research. So I think it's critical that when we're developing our tools as Africa, but also with international partners, we begin to share these tools, because there's no ground zero. There's limited resources, both finance, but also in people. And so it's critical that we share various resources, whether it's vaccine confidence, explaining vaccines. In terms of the question, it's a question that's been asked about HIV, and I'm an HIV researcher taking on COVID work now, is that what we need to understand is three factors. The two viruses, COVID-19 and HIV virus, are different from a physiological, biological point of view. The second is that the COVID vaccine was able to come out rapidly because for the first time in the history of health, national, international donors, scientists, advocates had no choice but to work together because this virus affected the globe. People were forced to let egos go, to come together, to share intellectually, and to really come up with an intervention. And it's amazing to have seen this for somebody who's been in the field for 2 decades of HIV. So that's very important to understand. And the third is that the platforms, and we do not want to become too clinical, but the platforms for these vaccines that were developed is based on existing interventions that like the Ebola vaccine. It did not start again on ground zero. And so therefore we were able to come up, these are some of the reasons, with the vaccine rapidly. Having said that, for those who are in the HIV world, as we all know, there are several vaccine studies happening in HIV, but because of the challenges and changes, we are aware of some of these clinical results that have shown that these vaccines were not efficacious enough to prevent HIV infection. And there's lots of readings and materials. And if you go to the AVAC website or the Sasonke website, one will be able to see some of these responses to these very important and critical questions that are coming up about the differences in HIV and COVID vaccine access and development.
Thank you, Nida. Thank you. And I trust that your question has been responded to, Nombasa. In case anyone else has a question, please feel free to unmute and ask your question, or you can use the chat, or you can raise your hand. I'm not looking at yes, you can raise your hand, and we will be able to pick on you to ask your question. Oh, Numbasa's hand has been up. Is this a new hand, Numbasa, or is it a follow-up question to what you asked in the chat?
No, yes, Alice, it's a new hand, but it's not a follow-up, but I rather had 2 questions on the chat. And because for me, I think it's important for us as civil society to be capacitated, because we are the ones that are mobilizing the communities. So one of the questions that I have, or I'm already almost asked, and I can't really give the answer to, is that most of the time when vaccines are developed, there are either therapeutic vaccines or prophylactic vaccines. But given the COVID-19 vaccine, it's one vaccine for all, and it's even given to those that have had COVID-19. So how does that work in terms of this COVID-19 vaccine? Because even myself, when I think about it, I can't really have good answers in answering that, even in the communities. Thanks.
Thanks for that question. Nida, would you like to respond to that too?
So that's a very clinical question, and so I'm not knowledgeable to answer it completely. But what I can say, Sizwe, is regarding the capacity development of civil society. I think in South Africa, there's been a move, especially in KwaZulu-Natal, to work with the civil society. And we've been very fortunate to work with the Provincial Council of AIDS. And, in fact, the chair of the civil society has actually joined a research organization now. So we are committed, both advocates and researchers, to ensure that the civil society groups in Africa and in South Africa are capacity developed and able to respond to these questions. So please call on research institutes including South African Medical Research Council, to address capacity development and to do some of these sessions. But your question is about giving preventative vaccines, if I heard you correctly, to people already infected with COVID. Now, my understanding of COVID vaccines is that we are not testing people before we give them the vaccine. And from the Sasonke trial, they've looked at the data, and I'm hoping that the paper comes out soon. We found that the 500,000 healthcare workers who were queuing up since February till May, they were people who were in the queue who already had COVID and were vaccinated. But there was no serious or adverse reaction when they received the COVID preventative vaccine, having had the virus already. The second point I want to make is that for those of us that have had COVID already, we had to wait 90 days post-infection before we could access the rollout vaccine in South Africa. So I'm hoping that explains some parts of your question. And others can help, please.
Sure. If anyone else has an addition to make, please feel free to unmute. Lillian, I see you're unmuted.
Oh, yes, I was trying to find the best way to also add cement on what Nee has said. I think your question also asked the role of COVID vaccines to people who already contracted the infection. And I think at the end of the day, what the vaccine does is to trigger your body to create defense or a memory, so that next time you get infected with COVID, you have fighters ready to attack the virus and help you not get severe symptoms or not get sick at all. So when it's given to a person who has already contracted COVID in the past, ideally, I believe it's just to boost their immunity as well. Next time they get it happens, they're exposed or get infected, they don't suffer the worst out of it. And it's necessary for us all to remember that once you're given a COVID vaccine, it doesn't necessarily mean that you are 100% not going to get infected, but at least it's going to you are sure that you're going to have mild symptoms in case it has to, or to stay asymptomatic in case you get infected. Thank you so much.
Thank you, Lillian. And thank you, Jessica. Hi, Dr. Rebecca. Please go on.
Hi, thank you, Alice. I just wanted to add a few words to what the previous speaker said with regards to the question of whether these are preventive or prophylactic vaccines. My understanding is that these are meant to be preventive in the sense that they prevent serious disease, the risk of serious disease or being hospitalized in the event that you do get a vaccine. And correct that it's meant to prime your immune system so that you are able to fight the infection when you do get it. Unfortunately, they do not stop you from getting COVID at all, which I believe there's vaccines in the pipeline that they are working towards that. But at the moment, the current vaccines are not 100% effective in preventing COVID disease. Rather, they are meant to prevent, well, they actually prevent serious illness for the majority of the vaccines in at least 80% of the people who are vaccinated. I hope that helps.
I hope that helps, Nombasa. At least it has helped me actually, because my community, knowing that I do lots of advocacy, one of the questions that they have always asked me is that, so then if we are not sure that we are 100% protected, why should we take the vaccine? And that was actually one of the reasons that we saw lots of hesitancy, especially the first time that vaccines had been rolled out in Uganda. Nombasa, Jessica has responded to one of your questions in the chat, and I think this is very good. Thank you so much, Jessica, for your response. Brian, do we have any other responses that I haven't been able to see, or questions that have not been asked or responded to?
Well, we are nearing the top of the hour. This discussion has gone by so quickly, but I wonder, we've been talking about some different communication strategies, whether that's social media, posters, community dialogues, and about the importance of really engaging and bringing on board as champions for vaccines some really influential leaders like healthcare providers and religious leaders. So I guess I just wanted to also open the floor to see if anyone has any final comments or thoughts, whether that's, communication strategies that you would recommend, or thoughts on how to really encourage some of these leaders to become champions for vaccines in their communities. Any suggestions or things that you're doing that or resources that you'd like to share with the group before we hear some final remarks from our speakers to close the session out?
I think what I want to add is that for advocates to be effective, their capacity needs to be built all the time. And you go out to advocate for a vaccine, and before you know, there are 5, 6 other variants that have come to the world, and you're unable to explain that this vaccine that you have now can address those variants, because there are still a lot of debates about that. So I'm thinking that we need to be a little bit ahead of community members, because they'll ask you questions that you don't have answers, and then it will not help the hesitancy. So I think we need to be on top of things.
Thank you, Charles. And just to add one of the points that Jessica noted, that as advocates, we actually shouldn't take it for granted that people are receiving accurate information. I think this is one takeaway point for me. And on that note, I would like to request Nida and Lillian to make any final comments, after which we will close. Lillian.
Thank you so much, Alice, and the entire team that organized this session. It's been really nice to hear from your perspectives, but also just having this space where we can clear some of the things that are disturbing from our communities as regards to vaccine hesitancy. And I hope moving forward from this space, we're going to create as many spaces and platforms where we get to discuss and openly share knowledge to ensure that people have better understanding of how vaccines work, but also get to the level where our communities have COVID vaccine and vaccines generally confidence, because I see this complicating if we're not careful at the time when we have a working HIV vaccine. If the hesitancy continues, it shows, I mean, that it could be a barrier next time we're about to roll out another vaccine. So it's necessary we pick out lessons from how we're introducing COVID vaccines into our communities and apply them in the future for the next vaccines that come out. Thank you so much.
Thank you, much appreciated. Nida, any final comments?
Thank you. So just to say that I think together we are able to address vaccine, enhance vaccine confidence. I like the word vaccine confidence better. The second is that it is really critical that we engage and conduct more behavioral research collectively so that we can inform our scientists about some of the issues that needs to be considered as they prepare and plan for either rollout work or for new clinical trials in any biomedical intervention. These lessons from COVID and other previous HIV research is critical so that there's trust and acceptance and use and uptake of some of these biomedical interventions in context of the social, cultural, and religious issues around our communities. So thank you very much for this opportunity and to learn from this group.
Excellent. Thank you, Nida. And, we are coming to the end of this discussion, of this meeting. The discussion continues. We will have a lot more going on. At least I'm sure Eva can be able to create a platform for us to continue with this discussion. Perhaps you can share that in our inboxes as you share the recording from this discussion. And many thanks to you, Dr. Rebecca, for the comments that you have made in the chat, and everyone else who has asked questions and contributed to the discussion. Special thanks to our panelists, Nida and Lillian, and to EVAC for convening this meeting. I thank you so much and have a good day.
Thank you all so much for joining.
Thank you.
Thank you.
Thank you. Have a nice day.
Thank you, Eva.